We have primarily in our practice, my experience, I have two radioisotopes. One is a gallium-68, one is a F-18. So do you guys have a preference with one or another?
The one, what's the one?
Clarify is the one
in
that-
our office.
Yeah.
So that's
That's
Yeah,
on our
that's-
formulary that we use.
I don't think we have a choice.
And that's a
Pretty much
gallium
is what they
68, right? That's a gallium-68 glorifies the brand.
Clarify, yes.
Yeah.
So actually, when I look it up, actually, I just want to share with you, there was one published the paper, actually, I like it. They basically recruit about 20 to 30 patients. They use gallium-68 and F-18 two PSMA scan to compare those scan results. And turns out, in most of the cases, they are very comparable with each other. However, they said F-18, like you mentioned, Dr. Babu, F-18 may have a higher chance to pick up some bony lesions, could increase the false positivity in the bones, the F-18. But overall, the conclusion is they are very comparable to each other. I guess in the real world practice, probably it does not make a whole lot of difference.
Yeah.
Okay, that's good.
I think it is, more relevant when we are talking about true biochemical relapse. But I use it in the beginning if I can get it, just to quantify the disease with all the other information coming in, the genetic data and all that. So if the patient course is not predictably, kind of a low risk, you already have all the information to decide on what to do with the second line.
Yep, that's a very good introduction. Actually, just leads to the next question. What factors or risk factors or characteristics, features you were paying attention before you decide how to treat our patients? Say, how do you decide the aggressive disease or moderate kind of latent disease? I always tell my patient, not every prostate cancer is equal. Yeah. So how do you, in your practice, how do you decide?
The Gleason score, the extent of metastases, if they're outside the spine and pelvis.
Volume disease.
Number of metastases.
Numbers, yes.
Really high PSA.
High
Doubling
PSA.
time of the PSA.
Doubling time, yes.
De novo versus a late recurrence.
Yep.
For me, it's like 4 metastases. One has to be outside the pelvic area and the spine. You have to have a visceral metastasis. De novo is also considered high risk. So for me, it's kind of that definition of high risk versus low risk based on the volume.
And,
I believe that's the Charter's criteria.
Location of the mets, definitely, because once you see liver mets, it's a bad news.
And if you have the Gleason from the prostate biopsy, it's very high Gleason. You generally expect those patients to behave kind of poorly.
That's good.
And then if you have the NGS, you see some P53, P10 mutations, all of those.
Or it's low PSA disease also. Low PSA
sometimes it
widely
can
spread disease. So this is very
widespread disease. Yeah. So how about the genetic testing result? There is germline mutation test, there is a somatic mutation test. Does that test result affect your decision-making process?
I order both.
You order both?
I order both. I'll get the germline and the somatic to get my BRCAs and the HRR deficiency ones. I think those 5 or 6 gene mutations.
Yep.
So I think there is some discrepancy that not one test is not able to pick all of the mutations. So I normally will check for both.
I don't know what the incidence is, but I've checked for, and I never get that. I haven't had any.
You don't find a lot of them.
I don't see them. I check it, and I'm like, who sees the BRCA? I don't.
Sometimes
I think
it's a. There is
two with check 2 mutations.
I have patients coming in, like in a batch. You got a few back to back, and then for a while you don't have it. So we need to NCCN guidelines. We all follow, and then it's recommended test. So I personally will do those tests. Have you guys ever run into a situation, patient has so-called oligometastatic disease?
Yeah,
So,
that happens a lot.
Yeah, how do you deal with those cases?
I asked radiation.
Yeah.
You do radiation?
I have one right now.
So it's a metastatic directed treatment.
Yep.
Yeah.
One lesion.
One lesion.
Especially the bone
I think
or
you
one
can-
in the lung.
You can radiate up to 4 lesions.
Yep.
Even oligometastasis.
The question there is, then do you treat for a limited duration or do you continuously treat? What are your thoughts?
ADT?
I'm continuing.
No, when you have
Systemic
oligometastatic
treatment.
disease, you've radiated it. Let's say that you have just one bone lesion or two bone lesions.
No,
you radiate and then you treat with,
I treat as a metastatic disease. Then I treat that, yes.
Yeah, I
Unless
continue,
patient
I
cannot
wouldn't,
tolerate, then I give
The
some
patient will
breaks.
tell you after so much time.
You think
they
patient's
can't tolerate it
preference,
forever.
patient's decision also may play
Would you keep it as an indefinite?
Unless the patient
Says
objects to
side
that
effects.
based on side effects. Yeah.
It's
She
not
knows
like-
metastatic. Even if you
It's
eat,
not that localized where you're like 2
Yeah.
years of ADT,
Yeah.
I'm going to stop.
Yeah.
Even with the radiation, you'll be like, it's a metastatic disease.
Right.
I think
Or
the
you can
patient
do-
has to understand that they know that it's not curable, right? And so that means it usually means indefinite treatment.
But you can do intermittent. Only if patient doesn't tolerate, then you give some breaks
Yeah.
once in a while. But otherwise, it's
Yeah, I don't know
yes,
whether there is
indefinite.
any ctDNA data in that setting.
Very good question. How often do you guys order ctDNA for prostate cancer?
I have not, but
I have
I'm thinking in a
Because
situation
the
like
PSA is
that.
actually good
You've
to
got a good
yeah,
biomarker you can
PSAs,
follow.
Yeah.
It's easy.
So I was just kind of thinking about the same question that once you treat them with radiation for 2 oligometastatic spots and you have radiated the prostate also, so now your ADT therapy plus minus androgen receptor inhibitor drugs, you leave them on for 6 months, 2 years, or you're like, I'm going to keep them going until unless progression or side effects?
I think there is no universal answers to that question. It's really individualized based on the patient, like Dr. Zimmerman mentioned. Patient sometimes has their preference, their goal, and also sometimes you look at the disease volume, the PSA doubling time, and then you can see what's the nature of the PSA. I think I have done everything. I have put the patient on non-stop systemic treatment because I believe even though this is oligometastatic disease, I really should treat this patient like stage 4 incurable disease. Some of the patients, I actually stopped the radiation with a short-term ADT. I stopped there. And the patient understand, we try to give it a chance for the cancer to prove itself, whether we took care of every known disease or every existing disease, or it will show up. And then if it shows up, we can decide re-identify the cancer and then re-challenge the disease. Like Dr. Epstein said, sometimes we do intermittent treatment. Some of the patients did really well on the intermittent treatment. So I think it really depends on the situation. It's a personalized approach to treat this type of situation. I don't think there is a universal answer to that.
I think that's where the Gleason score kind of comes into play. When they are scoring 8, 9, they don't.
Yeah.
Those are the ones that they
they're
don't.
not doing well.
Yeah. 6, I guess you could. You could say, hey, maybe treat short term and then watch. But from 8 and 9, whenever they don't, they just seem to progress pretty quick.
So if you do intermittent, when do you restart the treatment?
Monitor the PSA.
Is there a number or a rate of rise that?
Not really. I don't think there is a cutoff. I think I go by the PSA doubling time. A lot of people use 9 months. That's 9, 10 months as my cutoff, and also the volume, and then patient's symptoms, and then it's sometimes you run into some cases with so-called low PSA producer. If that's the case, you cannot solely rely on PSA.
Yeah.
You need to consider imaging. So I think there's a lot of approach we need to take into consideration.
I think one of the issues in that setting would be, are we talking about just giving a drug like, Lupron, or are we, adding a novel agent in addition to that?
ARPI, yeah.
So anyway, that's we don't have answer for that. I have a question for all of you. It's like when you add, when you choose to add Abiraterone or anti-androgen therapy in addition to ADT, do you pick Abiraterone or one of the novel agents? Because we all know that, in some patients Abiraterone is all you need, but it is a little complicated with the prednisone, and the older patients will have trouble. And I have patients where Abiraterone stopped working, and then I went on a novel agent and it worked. But it generally doesn't happen the other way around. And I wonder whether we should be using abiraterone first, although, in most patients, because we may have a second opportunity with another pill. But I think the data is kind of confusing. Do you have any thoughts on that? Or?
So from my experience, what I've seen is whenever they fail, I haven't gotten anyone to respond after they failed Xtandi or Zytiga.
So you mean if they fail one ARPI, if you do the second one?
I haven't had a very good luck in re-challenging with another.
Literature says 20%, some are there 10, 20%, but I think it's personal.
Actually, I had a patient who who's 96 now. So he went on abiraterone when he was 83 at the VA. Then when we stopped going to the VA, he switched to me here, and he used to go to Mayo Clinic and everywhere. And right before COVID, he started progressing, and he's like 90 by then. And I said, there's nothing to lose. We'll try enzalutamide. He wanted to go to Mayo, but flights were shut down and nothing was there. He is still on it, and the PSA went down. So, and then I kind of explored the data, and you see that 20-25% of patients who are on abiraterone, they will respond to the other agent, but not the other way around.